It's rare until it happens to your friend or family members or to yourself, and then it's not rare anymore. You want the best treatment options out there, and you always look for a cure.
Overall awareness remains a major gap in rare kidney disease care, on both the patient and clinician side. But with promising advances in biologic therapies and enhanced insight into disease pathology, including new FDA approvals for disease modifying therapies for IgAN and C3G, along with updated 2025 KDIGO Practice Guidelines, clinicians shared optimism for the future of the field with HCPLive for Rare Disease Day 2026.
So, rare kidney disease, as you said, is rare. So, I think the problem is that during our training, we only see X number of patients. We might follow them for maximum of 2 years. So, there's lack of proper longitudinal training.
C3G is about zero point 0.2 to 2 cases per million people annually. So we are talking about an ultra rare disease. A lot of physicians might not be comfortable treating C3G because they've never seen a patient before and they don't feel comfortable starting treatment for these patients. So that causes a lot of referrals, many appointments for the patients. And by the time that they're seeing an expert in C3G, they've seen so many doctors, they've heard so many different opinions, and they even sometimes like they feel like really disappointed, and they feel like they have to give up.
Although IgAN may be more common than C3G, it presents many of the same challenges and is the most common form of primary glomerular nephritis worldwide, with an estimated global incidence of 2.5 per 100,000 people each year. In both these conditions, early diagnosis and timely intervention are critical to preventing kidney failure, underscoring the need for greater clinician awareness and specialized expertise.
That's why there's a lot of emphasis on specialized education. More glomerular nephritis fellowships have come back, and more GN centers, so glomerular nephritis centers, have come up to try to help the community nephrologists and other physicians to take care of these patients with rare kidney disease.
For many years, the treatment landscape for rare kidney diseases was extremely limited. In IgAN, therapies largely focused on supportive care, including reducing proteinuria and controlling blood pressure, rather than targeting the underlying disease process.
Areas. We know we can reduce proteinuria by using an ACE inhibitor or an ARB, or an endothelin antagonist, or an SGLT2 inhibitor. But is that the same thing as blocking the production of galactose-deficient IgA1 and the immune complexes? And most people think not.
For C3G, the challenge was somehow even greater. There were no FDA-approved therapies at all, and clinicians often relied on off-label treatments, adapting immunosuppressive or complement targeting strategies without disease-specific approvals. For patients and providers alike, the limited options raised high levels of uncertainty.
For C3G, we didn't have any FDA approved medications for treatment of C3G. So imagine getting diagnosed with an ultra rare disease that you've never heard of the name, not knowing if there are any actually medications out there that can help you to preserve your kidney function. We were using off-label medications based on our KDIGO guidelines. We didn't have any FDA-approved medications for these patients, and some patients responded. Some patients had multiple relapses over time. And as I said, the risk of ending up on dialysis for patients with this kind of disease is kind of high, and that's something that patients had to deal with it.
The time when we did not have update on KDIGO, National Kidney Guidelines, since 2012, and now we've had update in 2021 and 2025. So a lot of us are kind of working together to try to make people more aware of rare kidney disease.
Historically, treatment approaches for IgAN and rare kidney disease were limited and largely reactive. Clinicians faced difficult decisions around when to perform a biopsy, how aggressively to treat, and which therapies could truly alter the disease course.
Nobody tested, nobody knew, and by the time they came to our door, we are late in recognizing it. So I think there are challenges in diagnosing it or detecting it early. And then treatment-wise, now we have a lot of advancements going on right now, but there's still a lot of gap in our understanding when to use what therapy and for how long. So there are lots of challenges, but I think we're moving in the right direction.
Recognizing these gaps, the KDIGO 2025 guidelines provide updated recommendations for early intervention, risk stratification, and mechanism-driven therapies. These recommendations reflect a shift towards precision medicine, enabling clinicians to act early and tailor interventions to each patient's risk profile.
I think that the 2025 KDIGO guidelines are actually very, very accordingly. moving with where the field is right now.
2025 KDIGO guidelines. One is biopsy the patients early. If you don't have a specific diagnosis and somebody has 0.5 grams of proteinuria or more, then you should be doing a biopsy. Also changed. So looking at now, we're trying to get the protein creatinine ratio in the urine down to less than 0.5, and if possible, less than 0.3, which is a very low amount of proteinuria. It's not always possible, but that's your goal of therapy. And your long-term goal is to keep the loss of kidney function down to less than 1 cc per minute per year.
So the two major acknowledgments are that we understand now that this is a disease that is not as benign as we previously thought. And that also, for the first time in history, we have mechanism-driven therapeutics.
Well, it should be combining strategies to treat both parts of the paradigm here. So when we look at this, we want to do our maximum things to decrease the proteinuria, non-specifically decrease glomerular hypertension, decrease proliferation in the glomerulus. At the same time, we want to turn off the process that led to this, that also will decrease proteinuria. And that's more mechanistically important, looking at the glomerulus in terms of ACE inhibitors and ARBs, SGLT2 inhibitors, endothelin antagonists, and those that change the glomerular inflammation and the production of galactose-deficient IgA1 and the immune complexes. So medicines such as Tarpeo, we know acts on the distal ileum and the Peyer's patches there, and it prevents the production of galactose-deficient IgA1 and the immune complexes, and also goes back and prevents the proteinuria in the kidney. Some of the other agents that are now being developed also block the production of the galactose-deficient IgA1 and the immune complexes, and also reduce proteinuria. And some act mostly on, the newer agents act mostly on the reduction of proteinuria and inflammation. So we have many places now that we can act on changing what the course is of the disease.
We have two newly FDA-approved medication. One is iptacopan. Iptacopan is a factor B inhibitor, and the other medication is pegcetacoplan. Pegcetacoplan is a C3 inhibitor. So both of these medications, if you look at the pathophysiology of the disease, both of these medications from the pathophysiology of the disease make sense. That should kind of help us to delay complications for these patients. Both of the clinical trials on these medications showed that they actually significantly drop the proteinuria, meaning that the amount of protein in the urine drops once you take these medications for these patients.
These drugs are very widely used. I use them all the time. I like sparsentan because it combines the efficacy of an ARB and endothelin antagonist, and it's a single pill, a single drug. And that's very good because, again, we're talking about using multiple medications in these patients. I like targeted release budesonide because it gives me the efficacy of steroids, but it's much less on side effects. It's really for the reduction in side effects that's a major thing. So you may get some people with a little bit of hypertension and edema, or somebody may have, mild acne with this. But that's very different than developing diabetes or infections that are the big worries with steroids, especially if you use higher doses.
There's a lot coming on in the horizon, and I think that now that treatment is out there, right, it is necessary to understand how to use them, as I mentioned before, how to combine them. And this is where real-world evidence actually comes into play. We have all the pharma research, we have all the mechanistic research. Now we have to see how to allocate the patients. And it's up to us in the community and as nephrologists to start using these medications and generate this data.
Multiple new therapies available, clinicians still face important questions. Should these treatments be used in combination or sequentially? And how can they be applied safely to maximize benefit? Other unanswered questions still remain, including how to translate these new options into real-world clinical practice.
Are we done with treatment options for C3G? Obviously not. And I'm hoping to see more options in near future, more clinical trials. I know it's a rare disease, but I always say that you're dealing with a rare disease that not only affected you on your native kidneys after receiving the transplant, after going through like so much of evaluations, complicated surgery, finding a donor, then it might come back with a really high chance. So we really need more research on post-transplanted patients.
Clinician. One is getting insurance approval. That there's often a delay in terms of this. And again, having a drug that is FDA approved and has its final approval, it's hard for insurance companies not to agree that this should be used in this disease. I mean, it's FDA approved for that reason. Now, if they have preliminary approval, they can always argue that there isn't endpoint data. So that's a difference in terms of this. So the other thing is using multiple medications. You have to talk to the patient and say, look, we're going to use several medicines at the same time. I know you're going to be starting a bunch of drugs, but it's important to prevent you from developing dialysis or need for transplantation. And, we think all the time that nobody, if they had a malignancy, would worry about the oncologist saying, take these 4 medicines, it's got the best survival rate. Well, it's the same thing. If you need multiple medications, we should be able to emphasize this combination is going to prevent you from going to dialysis long term.
Difficult things is trying to understand how to allocate all of these resources into specific patients. We also have not answered the questions of how are we going to use these resources in the future. It says we understand that these patients have been enrolled in trials for 1 or 2 years. What happens after discontinuation of therapy? Do we need to continue therapy indefinitely? Is this actually really truly disease modifying, or are we just controlling the disease process? All of these questions need to be answered. Now, moving forward in research, having available options actually limit our ability to do trials. It would not be ethic to actually have trials that are placebo controlled. So we also have to redirect the way that we do trials to fit for those patients and to give them a fair treatment and not actually enrolling them into a placebo.
So I have a lot of expectations. Number one, I feel that we will have newer markers to detect the disease and monitor the disease activity without going back to doing kidney biopsy to find out what's going on. So new urinary biomarkers should help us. 2, I feel with the newer therapies, and then as we get more comfortable in using them and we have more long-term data for the newer therapies, then I think we'll be better able to control the disease, and hopefully we can prevent a large number of patients progressing to end-stage kidney disease or requiring kidney transplant down the line. So there's a lot of new innovation is happening in the field of nephrology and especially the rare kidney disease side of things. So I'm very excited, and it's always great to find out there's so much research going around us and we're having positive results.
On Rare Disease Day, we highlight the challenges and breakthroughs in rare kidney diseases. With these new therapies emerging, clinicians have tools to act earlier and more precisely, and patients now have a reason for hope, a future where these diseases don't have to define their lives.